So welcome everyone to the next session by Ryan Howells on the CARIN Alliance. For those of you in the room, please use the microphone during the Q&A, and for those online, please use the Q&A for questions. Ryan, please start with introducing yourself. Thank you.
Thanks, Reen. Thanks everybody for joining today. We appreciate it. We've got a lot of material to cover, so we will jump right in. First things first, just kind of a quick introduction of myself and what we do. I work at a company called Leavitt Partners. We focus on convening multi-sector stakeholders to solve really difficult issues in healthcare. And one of the stakeholder groups and alliance groups that we actually manage is the CARIN Alliance, which is an HL7 Fire Accelerator program, one of the three original ones, and involved in a lot of different other things. And so we're going to talk about the work that we've done in CARIN, specifically to advance an ability for consumers and their caregivers to easily get, use, and share their digital health information. That's our vision, is focusing on moving data between regulated environments. How do we find ways where that data can be moved in a seamless way between both the HIPAA-regulated environment here in the United States as well as the FTC-regulated environment, safely, securely, and in a privacy-centric and consent-centric based way. We've got about 80 organizations that participate in CARIN in some way, shape, or form here in the US, and looking for ways where individuals can actually access that data at scale. One of the things that we've worked on historically and have been working on for quite some time is Blue Button. Blue Button is a CMS-related project that allows for an individual to get access essentially to their explanation of benefit information, which essentially says how the health plan actually paid for their specific clinical encounter. And Blue Button was definitely a private, a public-private partnership that has existed since 2018, where Administrator Verma from CMS actually announced the fact that CMS was providing this Blue Button functionality. And over the course of the next few years, we worked in concert with CMS to actually release a standard through HL7, which is the CARIN IG for Blue Button, that allows for individual consumers to aggregate their payment information from the health plan of their choice. And that was published in the 2019 timeframe. 2020 was when it was first balloted, and then we moved into production with that. And each of the individual health plans didn't need to create their own standard for how that occurred. And so we used a data model called the Common Payer Consumer Data Set, because we needed a way to express this information in a standardized way across different payers, which didn't really exist at the time in terms of how that actually would operate in fire. And so we did that. It was in line with the rule, and CMS pointed to it in subsequent guidance and published the STU1 version in November of 2020. We had some minor technical corrections last year, and we actually balloted STU2 this year, which includes both dental and vision as part of that effort. We anticipate that IG is going to be published in Q3. You can read all about it on the IG page. We're certainly available in Confluence and chat.fire.org and all the other places that you can find us. And have open meetings, obviously, with HL7 to learn more about the work that we've done in Blue Button. But I think what's really exciting about this, being in the fire community, is that, and this is a little bit more about the workflow, is an opportunity for this workflow, very standard in terms of OIDC. When you link, you fetch that explanation of benefits, get that patient ID and token, and then those supporting resources get returned. So it's pretty standard. But what I was going to say is, what's really exciting about this is, as a result of that public-private partnership, we had a significant number of health plans that actually became fire compliant. And when we started this process back in 2018, most of the health plans in the country literally could not spell fire. That's really kind of where we were at the time. And they didn't have fire resources. They didn't know where to go to get them. They came to DevDays, they came to the HL7 Connect-a-thons, they came to CARIN, they came to all these places, DaVinci and other places where they were able to aggregate. And what's really exciting is we believe that about 84% of all the plans are either fully or partially compliant with that within a time period of only 2 years. which is certainly remarkable. We've got some friends, Mark Scrimshire at Onyx Health, that actually tracks that for us online, that you can see which of those CMS actually plans are compliant now. So we're super excited about that, because now we have both a provider and a payer infrastructure for exchanging FHIR APIs. The other implementation guide that we work on is what's called the CARIN IG for real-time pharmacy benefit check. This allows an individual consumer to get access to their real-time information for benefit and formulary information, out-of-pocket costs, therapeutic alternatives, and their cash price. Very transformative. We think that there's at least a 50 to 75% discount over pharmaceutical costs by having this information in their hand. US regulation actually requires on the B2B side for the individual, the patient, the provider, to actually have this information in their EHR, which is live today. This is more enabling and empowering the patient with the information they need, similar to what the provider has, so that there can be a real-time conversation between the patient and the provider about which individual therapies are most efficacious for them, and how they and where they actually want to be able to dispense their drugs, and which pharmacy they want that drugs to be dispensed, which that cost varies widely. There is a regulation that's in place that requires this to be available, requires this type of technology called real-time benefit tool to be available sometime by January 1st of 2023. An API is one option for that to be available, as well as a portal type functionality. And we're working with a number of PBMs this year to actually make that real and available, including working with both NCPDP and HL7 to ensure that the standard is updated accordingly. This is the workflow around real-time benefit check that talks about the use of a patient mobile health application, where they go out and get the coverage cost, the coverage resources associated with that, as well as the cash price alternatives. A little bit more on the request and the response, and which of the resources that we're using in terms of claim and coverage, medication request, et cetera, and then what is actually being responded to in the bundle. By the way, all these slides are online, so you can see them afterwards, and I apologize for going so quickly, but wanted to touch on a few things as we have time. We have, as I mentioned a little bit earlier, we have synced up this standard with that NCPDP standard. So again, to reiterate, NCPDP has a standard to do EDI-related transactions, B2B, between the PBM, that's a lot of acronyms there, but the pharmacy benefit manager and the provider that's requesting that information here in the US. That's what NCPDP does. And then we are providing the FHIR-based standard for consumers to actually have access to that same information. We have tried to remain in sync with NCPDP from the very beginning. It's a dual project between us and them. And most recently, they have met and have determined, again, that our standard will become the consumer-facing standard that they will use, as well as obviously the HL7 community is going to be used as well. It's been a couple of years since the standard has been out, and they've made some changes to their side, and so we're reconciling just a few of those, about a half dozen or so different changes that we want to potentially make on our side. But you can be assured that as we are moving forward, that the B2B standard and the B2C standard are both going to be in sync, both between NCPDP and HL7, largely due to the collaboration that we have with them, which allows it to be a lot more, a lot easier for developers, as well as a lot more transparent to consumers, so that they can have the same access that their individual provider actually has. We're excited over the last 6 to 9 months in working on what we call the CARIN IG for digital insurance card. This gives a patient the ability to take the information that's on their paper insurance card and put that in a FHIR API format, largely for CMS-related plans, again, here in the US. There's not a regulatory requirement for that occurring, but what this enables us to do is similar to the workflow we have today in the US, where you pull out your insurance card at a pharmacy, for example, they take it and scan it and fax it and do all the paper-based things that they do today. This allows an opportunity for you to actually have that in an app in your phone, share that information, or even upload that information, which I had to actually do to get tested to come out here to DevDays we had to get COVID tested, and so I'm handing them a paper card. They're doing their thing on their side, but they also have CVS, for example, had ability to upload your paper card into that. Now you can upload a FHIR API to make that actually happen, a much more streamlined ability to do that. And what we envision is that as a result of that, as well as the digital identity work that we're going to talk about here shortly, the combination of those two things allow you to seamlessly integrate with your health plan in a way that we've never been able to do before online using FHIR-related APIs. So more information there online. This talks a little bit about the workflow, very similar to kind of a standard workflow that we've seen with Blue Button, but we'll go through a Smart on FHIR process, at least at the beginning. It'll enter the credentials and the OIDC token is returned. We'll fetch the coverage and associated resources associated with that, and they'll send back the information and the data accordingly. But again, the value associated with this is that it's not an eligibility transaction per se. It's actually the transaction associated with just sending the data in the card. The eligibility transaction is still going to be done by either the pharmacy or the provider, just like they would do today. We're just actually sending the data from the card itself. Let's talk a little bit about digital identities. It's a little bit outside of FHIR, but I think it's super important as we think about how FHIR is going to scale in the US. So yesterday, the ONC had an opportunity to talk about what they're doing in terms of a FHIR network model and how to scale a FHIR network model with this second version of TEFCA that's actually coming out. In order for that to happen really accordingly, we've got to have also an ability for an individual patient to then be able to prove that they are who they say they are and use that multiple times across multiple systems. The challenge we have today is we have Smart on FHIR, which is great, fully supportive of what Smart on FHIR does, but a patient like Dave or others that actually have some type of a chronic condition have to remember their usernames and passwords for every single portal they've ever been on for their entire history of their life. And for those who have chronic conditions, they'll have dozens of portals that they have to remember, and it's very insecure. A lot of those usernames and passwords are on the dark web in doing that. So where the industry is going, not just healthcare, but outside of healthcare, is the ability to create your own digital identity. Mobile driver's licenses is one example of that, where you'll be able to have that stored in the hardware of your phone very safely and securely. You'll be able to share only the information that you would like to with an independent third party. So when you go and for whatever use case it is, and they need to find out information about you from that digital identity that's been authenticated, you can just share with them only the information that they need. So it's highly secure, very privacy-centric, first-based approach. And our hope is that we can actually figure out a way to federate those digital identities across a FHIR networked ecosystem. So we wrote a landmark paper with the OpenID Connect Foundation back in December of 2020 around how we envision this process to work, how we're going to actually federate digital identities across an ecosystem that you can read a little bit more about online that we have. But what the core of the paper talks about the NIST standard, which is called NIST 863-3, which involves 3 different layers of identity proofing, identity assurance level 1, 2, and 3. NIST, for those who don't know, is the U.S. government's way in which all the federal agencies meet the identity proofing requirements. IL2 has actually been identified as being the standard by which individuals get identity proofed going forward, and it's the one in which TEFCA and others have actually found a way in which they can be able to use it. And so CARIN and TEFCA and ONC and Commonwealth, Carry Quality have all recommended now that if an individual is using a third-party app, they're going to get digitally identified using an IL2 credential. That's how we're going to raise the bar in terms of digital identity today in healthcare. Healthcare right now is somewhere between an IL1 and IL2 level. And so we're trying to raise the bar in terms of identity proofing across the board. And so we have said, well, that's great, but we actually want to get real technologists and real policy folks in a room to actually test it. So this year, we have a proof of concept that we're doing with about 20 organizations and the Department of Health and Human Services for how to federate a digital identity across an open source framework. It involves 4 major pillars, and I know I'm going super fast here, but I think I've only got 5 more minutes. So the major pillars are that we have an identity broker, which is the Department of Health and Human Services. They actually have a framework actually technology solution that's in production today that actually enables to be an identity broker service that can essentially act as a single sign-on for healthcare. So if you can imagine coming to a website, and when you come to that website, you're going to have 2 options by which to log in. You can log in using your MyChart account or other thing related to doing that, or you can log in using a SSO-like dropdown to say, I want to log in with login.gov, ID.me, all of these different OneCosmos, other folks that have actually been able to make that happen. And so any of those that are in the HHS XMS system that has been certified by one of these trust framework organizations that issue an IL2 credential, you could actually log in with that. We're defining a standardized credentialing policy that across trust framework organizations, and most importantly, we're getting the legal and business teams involved in this, because what's going to have to happen is if you're a relying party and you don't prove someone's identity yourself, you're going to have to accept this identity credential from another third party. That's the only way that this actually works at scale. So we've got to make sure the CISOs, the chief legal officers, are okay with that type of a model, and so they're going to be able to sign off on what we're doing. This gives you an example of all the different organizations that we have participating in this. You've seen a lot of them, but a lot of big name healthcare companies like Cambian, CVS Health, and Cedars-Sinai, and Kaiser Permanente here in the US, as well as ONC and CMS are directly involved in this as well from an observation perspective. A lot of different credentialing service providers and third-party applications that are participating. So I know it's a little bit outside of FHIR, but it's super important for us to extend FHIR is to figure out a way to do this at scale. And so if you're interested in digital identity, we'd love to be able to talk to you more about it. We think we're actually farther along than many other industries, including open banking around the world on this topic. So last slide I think that we've got, and we can turn it to some questions. Just again, other non-FHIR projects. We're a FHIR accelerator. We do implementation guides that we talked about, but we also find ways where we can do other things. One is when we're moving data between regulated environments, we have to have a way in which we can enforce the fact that that individual third-party application is following the highest degree of privacy, security, and consent-based ways in which they're storing the information. And we do that through the CARIN Code of Conduct. That's a self-attestation, but it's enforceable by the federal government and enforceable by the private sector. And so we've been able to list all of the apps that have attested to the CARIN code on what's called myhealthapplication.com. So consumers and health plans and providers and others can see who have actually voluntarily attested to that higher level of security. We've made a lot of policy and regulatory comments to the different regulatory agencies that you can read about in terms of our opinion on certain topics related to patient access. We've got helpful links for those who are actually creating their own third-party applications on our website that actually shows a lot of the things that are right out of the box. We have people calling us all the time that want to create a Smart on FHIR app. They'll do it in a couple of weeks, and instantly, thanks to Apple's help and others' help out there, VHA and CMS can get access to all kinds of information in a securely and privacy-centric way. And then we have a new work group that's actually working on delegated access and digital identity for a HIPAA personal representative and a minor. So if you're in the kind of the camp of trying to understand how delegated access works and digital identity for minors, we'd love to talk to you, but that's a big issue, especially for state Medicaid agencies where half of the population that they serve are actually minors. Final thing I will say is application registration guide. For us to be able to really have an app-based economy, we've got to figure out a streamlined way for doing app registration at scale and getting the client OAuth secret in a seamless way. We've written a 50-page guide that's out there that we would love feedback on, that we'd love for you to react to and provide us some feedback. We'd talk to anybody and everyone to make that happen, and hopefully a lot of these best practices we'll be able to get into the FHIR version of TEFCA actually once it comes out and other things that are happening. So here's all the ways to contact us, Zulip, Confluence, all the standard ways to do it, my email as well. I know we've got about 1 minute left, but happy to answer any questions that may have come in. Reen?
Thank you very much, Ryan. I have a question here from David Simons online. Are you considering using QR codes, perhaps embed selected FHIR resources in the QR code for standalone use?
Yeah, so QR codes are interesting. They limit the amount of characters, obviously, that are in the code itself. Smart Health Links may help in that sense. We worked with the VCI.org. We were on the steering committee there and doing smart health cards, which was great as far as getting that off the ground. I don't know exactly what he was talking about, but right now we just got to get the APIs to work. Once we get the APIs to work, we want to put it in a QR code or blockchain or anything else, distributed ledger.
First the APIs.
Just the APIs
Okay.
first, yeah.
Yeah. Any questions from the room? Otherwise, maybe I have a question.
Okay.
There's a lot of work that you're doing on identity that may not be restricted to CARIN, right? How do you align with the other accelerators in this field?
So the other work that's going on in identity right now is, well, we talk to the accelerators every month, number one. Number two is there's some work going on the Fast Digital Identity Tiger team, which I've been a part of for the last couple of years. All of the work that they have done are very consistent with the work that we have done. But the implementation guide that's being developed by the Fast Digital Identity Work Group is not going to solve our problem. There's a lot of policy hurdles that we need to encounter and understand and then solve for, I should say. And then we also need to find ways where we can be able to literally put this in production and figure out ways where people are comfortable with the fact that they're not going to prove someone's identity every time. So that's what we're doing this year. We'll write up that report, make it publicly available so that everyone can be able to see and access it and kind of go from there. But there's a lot of coordination going on between the different accelerators right now related to that.
Thank you very much for taking questions. Ryan, thank you very much for the wonderful presentation. And with this, I would like to hand it over to the next session. Thank you very much for joining us.
Thanks all.